Amazing. Okay, I think we'll go ahead and get started. Thank you everyone for joining. So excited to have this conversation, especially just given so much of the overlap that happens with eating disorders, disordered eating, and PCOS, and so many other hormonal conditions. Maybe we'll just kick us off with a few intros. Just as a quick reminder, to just please mute if possible, so we can make sure that we're able to proceed without any disruptions. Amazing. Thank you all. Great. So just to kick us off, my name is Joan Zong, and I am one of the co-founders of Arise and also our Chief Product Officer. I have experience on both sides, the PCOS side and the eating disorder side, which makes this conversation particularly interesting and relevant to me. This is a little bit of background. I was diagnosed with an eating disorder my freshman year in college, and then really struggled with disordered eating more broadly just many years after, because I discontinued my treatment really early. And I think because of that, it actually led to a pretty long delay to actually getting that PCOS diagnosis. I was really afraid that, I spent so much time and energy on my eating disorder recovery. I was really afraid that going to the doctor's office and kind of troubleshooting why I wasn't having a period, why I was experiencing all these symptoms, that they would just tell me, diet and exercise, because that's what everyone was kind of saying online and what I'd always hear. And, even just the like act of having to get my weight done at the doctor's office and like being kind of shamed for that was really intimidating, and rightfully so. And so led to many years of not getting any care, even though I knew something was wrong. And I think it got to a point where I was like, I gotta look into this, because this is really dangerous, actually. Around that time, I actually found Allara, and I was like, okay, let me check this out. And it's virtual, so at least they won't take my weight in the office. And I was so thrilled that it was just such a seamless process, and that the providers really understood my background and context with the eating disorder, and were really focused on the insulin resistance aspects rather than like telling me to just lose weight. And it was just such a comforting space. And so really excited to have Dr. Erica Gerasa and Felice here, to really just continue this conversation, because there's so much overlap. And I think so much of the existing dialogue is so focused on and so triggering to folks with eating disorder or disordered eating. So I'll pass it over to Felice to do a really quick intro.
Hi, everybody. My name is Felice. I'm lead dietitian at Allara. And I really started my path down PCOS nutrition, that focus, after receiving the diagnosis of PCOS myself. So very often when I'm counseling patients, I can see so much of my own experience in theirs. And with this, overlap with disordered eating, it was really this overlap in conditions, disordered eating, PCOS, which we'll get to later. It really was able to deepen my passion in both of those things, and I'm very excited to talk about it today.
Amazing. Thanks so much, Felice. And Erica, would love to have you introduce yourself as well.
Thank you. And thanks to both of you for sharing your story and just for being so open and transparent. I'm glad we get to kick off the conversation that way. It's so nice to meet all of you. My name is Dr. Erica Gerasa. I am a child, adolescent, and adult psychiatrist, and I specialize in the treatment of eating disorders. And I am also honored to be the Chief Medical Officer of Arise and the board chair of Project Heal, which is a nonprofit which is really dedicated to breaking down barriers in eating disorder care and access. So it's really a pleasure to be here tonight.
Amazing. Well, to kick us off, the intersection of PCOS and eating disorders, the important question we're all asking today. Maybe you could just give us a little bit of background. Felice, do you mind walking us through what PCOS is?
Absolutely. So PCOS is a condition that affects about 10 to 20% of females, with symptoms appearing as early as pre-puberty and lasting after menopause. I always like to hammer home that this is a hormonal or endocrine condition, not a reproductive one. Oftentimes it's our OBGYNs that treat it, but it's really a full body hormonal condition. It presents as hormonal differences, elevated testosterone, insulin resistance, and other reproductive and hormone differences. approximately 80% of people with PCOS have insulin resistance, which is sort of the first step towards the pathway of type 2 diabetes, just because of the really strong genetic association of those things. So we really try and look at that and focus on that beyond any other factor in treating PCOS when it applies. And for diagnosis, if you're not familiar, to have PCOS, you must have at least 2 out of the 3 criteria, which are listed here: elevated androgens or the symptoms of it, irregular absent cycles, and polycystic appearing ovaries on ultrasound.
Yeah, and I think it's so important to like think through that there are so many different symptoms that can present, and it's not that everyone will have all of this. I was actually just chatting with someone over coffee this morning. We both discovered this morning that we had PCOS, and we were sharing like we had completely different symptoms. And I remember when I was like doing research initially and trying to figure out, do I have PCOS? I was like, oh, well, I don't have all of these, so I don't have it. And it wasn't until I talked with Dr. Hennigsman that I realized, oh no, like it doesn't have to be all of these. And actually a lot of people won't have all of these symptoms. So it's really fascinating.
Absolutely.
Awesome. And I'm sure everyone here is probably very aware of what PCOS is and might have personal experience. And wanted to just cover some of the, other symptoms with PCOS. I think we mentioned some of these, but please, any others that you want to highlight?
Yeah, I think one that doesn't often pop up in the internet search is intense carbohydrate cravings, which is like so highly associated with the insulin resistance piece of PCOS. And I think cravings or feeling out of control around food can be really normalized in our culture, but it can be a sign of something deep below the surface. Really low energy or fatigue is another one. And then paired with trouble sleeping, sleep apnea, acne, oily skin, difficulty conceiving, or infertility, which is when the majority of people find out that they have PCOS, is when they're actually trying to conceive. But some of the more common, symptoms are the things associated with the testosterone, like excessive body hair growth, thinning of hair, stuff like that.
Yeah, it's so interesting because I think so many of these feel like it's like just this negative cycle that's going to perpetuate the eating disorder or vice versa. Like I think, having the intense carbohydrate cravings definitely impacts your eating behaviors. And then the lack of energy. I remember like it felt so hard. Like I had a therapist who was like, oh, like, can you try to go for a walk in the evening? And I was like, I don't know how to tell you, but like, I just have no energy. Like I just want to be flat, like lie horizontal. And it makes it so hard to really manage the eating disorder and all the stuff that comes with it. It feels like it's kind of this, snowball effect that ends up happening.
Absolutely. And it was crazy to think how fatigued I was, and I didn't realize how abnormal that was until I finally felt better. And I was like, oh my gosh, like I can get out of bed in the morning. I don't need an 11 a.m. nap. This is so weird.
Yeah. Yeah. Yeah, it's wonders what can happen when you start to actually understand your health a little bit more and have providers who really focus on explaining, the details of this, like, oh, if it's insulin resistance or what is causing this, and actually digging deeper than just saying, oh, we'll just go, diet and exercise, and then let's talk. I think that's been so important. And Erica, would love to have you just give us a brief overview of, what eating disorders are. And I know a lot of times folks might not identify with having a diagnosed eating disorder, but also, what is disordered eating?
Absolutely. So, it's really important since we've outlined what PCOS is to really outline what an eating disorder is. If you were to Google eating disorder, more than likely you're going to find a lot of information about anorexia nervosa, and you may see a lot of pictures of emaciated, really thin white women with an eating disorder, typically anorexia nervosa. But the reality is there are so many other kinds of eating disorders. And yes, anorexia nervosa is one of them. But as you can see here, there are multiple types of eating disorders. It's there's so much diversity when it comes to eating disorders. So we have bulimia nervosa, binge eating disorder, which actually is the most common eating disorder in the United States. And that is something that we see co-occurring with PCOS, binge eating disorder, and bulimia nervosa. But other types, pica, rumination disorder, these are different types of eating disorder you typically don't really hear about are fit. We won't go into all the details about eating disorders, but I do think it's important to understand that an eating disorder can be very different from disordered eating. And disordered eating means that there can be behaviors that one might engage in that are disordered and that can actually cause impairment in their lives. And these are just a few of the different kinds of disordered eating behaviors that we see. One being restriction, and restriction, as you can see, can have lots of different types of behaviors underneath it. So, just reducing food intake, dieting, which unfortunately a lot of individuals with PCOS are told to start a diet. And that can lead to an eating disorder or disordered eating behaviors. Counting calories, eliminating food groups. I can't tell you how many times I've heard people tell me that they cut out carbohydrates altogether. And as Felice mentioned, that can be a challenge when the insulin resistance is causing carb cravings. And we'll talk a little bit about the cycle that can happen with that. But eliminating food groups, clean eating. We already got some questions from the audience about orthorexia. And oftentimes, even though orthorexia is not a typical DSM diagnosis of an eating disorder, it still can cause a lot of impairment in one's life. And it can cause them to be excessively preoccupied with food and also to miss out on key nutrients like fats and carbohydrates. Oftentimes, when people refer to clean eating, they mean only eating pretty much protein and vegetables, which is an issue. Skipping meals, fasting, hiding food, and also not eating with other people. And I think that's important to highlight because disordered eating behaviors and eating disorders oftentimes are very isolating illnesses. And they tend to happen in secret. And the reason is because a lot of people experience shame when it comes to disordered eating patterns or eating disorder behaviors. And that shame can lead individuals to then engage in those behaviors in secret and then can further perpetuate those behaviors. So we can see a lot of those behaviors kind of cross-sectionally with PCOS. Another group of disordered eating behaviors that we'll see are binging behaviors. And that's really when people will eat excessive amounts of food in a short period of time. And again, as Joan and Felice already mentioned, we can sometimes see binging behaviors with PCOS, again, because of the hormonal changes that are happening naturally in the body. And again, with that insulin resistance, that can increase cravings, which can then lead to binging behaviors. And we'll talk a little bit about how to handle those behaviors later. But I think it's important to know because, again, that shame can cause one to think like, oh my gosh, I must be the only person struggling with this. But that can feed into the PCOS and vice versa. The other thing about binging behaviors is that when people can feel out of control with their eating, and it can happen in a very short period of time, and again, can lead to a lot of feelings of guilt and shame. And then other types of eating disorder behaviors that often we don't really think about are body checking behaviors or avoidance. So compulsively weighing ourselves or measuring ourselves, looking in the mirror. And again, we may be told to do that sometimes even by our medical providers, to check our weights frequently, to make sure that we're moving in the right direction and making progress. And unfortunately, all too often, we see so much of an emphasis on weight with PCOS treatment. So we'll talk a little bit more about that. But these are just a few of the other things, making comparisons to others, avoiding certain types of clothes or pictures, and just excessive preoccupation with our bodies that in a very judgmental way. And then, of course, purging and other compensatory behaviors like compulsive exercise can also be features of eating disorder behaviors.
Thank you so much, Erica. And I just one really quick question, because I remember thinking and debating this in my head a lot. What would really be the difference between disordered eating and eating disorder? And like, does one mean that I should seek help and one mean that like, oh, I, don't need clinical care? I'm just really curious. I'm sure that's a question a lot of our folks have.
Yes, absolutely. So it's such a good question because looking at this list, I'm sure there are quite a few of us who can relate to some of these behaviors. And just because you have these behaviors doesn't necessarily mean that you have an eating disorder as defined by the DSM-5 criteria, which is a diagnostic manual that we use in psychiatry to make psychiatric diagnoses. However, you can have subclinical features of those disorders. So you may not necessarily meet the full criteria, but those behaviors can still lead to impairment. They can lead to impairment because they can cause physical symptoms. They can still cause hormonal challenges that we'll talk a little bit about. They can lead to really negative thoughts about ourselves, which can then lead to depression and anxiety. So it can still be necessary to seek out treatment if you're engaging in these behaviors and they're causing a problem for you, and again, leading to that functional impairment in your life. So you don't necessarily have to have a disorder to seek out that treatment. You can work with a therapist or a dietitian who can help you have a better relationship with your body and a better relationship with food.
Thank you so much. Awesome. And here's just a quick overview of some of the different thoughts and feelings. Erica, any in particular that you want to highlight?
Absolutely. I think, we highlighted it a little while ago that oftentimes we will be prescribed a diet or told that, the emphasis is really on weight loss when dealing with PCOS. And I think that can lead to a lot of body image distress. Again, being highly preoccupied with our body image and food and exercise. One thing that I always ask the folks that I work with is, what percentage of the time do you actually spend thinking about food or thinking about your body? And if that number is high, even if you don't have a full eating disorder, that means that, it's taking up a lot of space in your brain that could be otherwise spent on relationships, work, other meaningful things in life. But we can get so preoccupied that that tends to be the only driver for us. And that can lead to a lot of low self-esteem, self-criticism. I think in our society, especially here in the United States, there's a lot of fat phobia and fat discrimination and stigma that we're dealing with in our society that can then become internalized. And that can lead to feelings of guilt and shame, especially if you're placed on a diet and it doesn't work, or you find yourself in a binge restriction cycle. That can lead to a lot of distress, and it can lead to feelings of self-doubt, feelings of failure, which can sometimes ultimately lead to a sense of hopelessness and suicidality and urges to self-harm, and it could really go down another path. And what we know about eating disorders especially, they are the second leading cause of death amongst all psychiatric conditions, second to opioid abuse and opioid use disorders. And that's because of some of the cardiac conditions that can happen, but also because of the suicidality that can happen when people feel such a low place because of all of the worth and the value that they're placing on their appearance and the drive to lose weight or the drive for thinness. Because of the fat phobia that exists within our society, and especially within our medical system.
Yeah, definitely. And I know, eating disorders don't have just one look. I mean, it affects everyone.
Right.
It's so unfortunate that folks in larger bodies, BIPOC folks, LGBTQ folks often have less access and are less often to be diagnosed. 6% of folks are underweight. And Felice, I'm really curious too, like in the PCOS space, do we see kind of discrimination as well with just how diagnoses are made across people of color and just folks who maybe aren't the dominant culture?
I could not name the exact statistics, but overall, yes. And a lot of times you'll hear, phrases or statements being thrown around like, well, you don't look like you have PCOS, or like, really, really typing PCOS as a specific look or appearance or things like that. And I think that's equally as harmful for large people and for thin people, because if you're
Wow.
large, like, what a blow. It's weight changes are a side effect of PCOS, not the cause of PCOS. And for thin people, it means they're unbelievably diagnosed and it takes much, much, much longer for them to get the treatment that they need. So absolutely. And yeah, anybody who's a person of color, anybody who's of a lower socioeconomic status, anybody in the LGBTQ plus community. These are all populations that have lower access to care, especially reproductive care. So it's very difficult to get diagnosed and then also to get the proper treatment.
Yeah.
And Felice, I can imagine that it's also really hard for those individuals once they do get that diagnosis of PCOS to then be screened for an eating disorder
Mm,
as
It
well,
really,
right? Because when we think about this population, and oftentimes disorders are completely, I can imagine.
uh-oh, there we go. Okay, I think we're back. Erica, we heard a little bit piece of that.
yes, I feel
Sorry
like
about that.
I feel like we got what mattered from that. So yeah, I would absolutely agree. It's very, very difficult to get the treatment, and a lot of the blame, when doctors do give their lifestyle recommendations, if they aren't seeing weight changes, they just say you aren't trying hard enough, you aren't listening to my advice. Lots and lots and lots of assumptions are made. And I can't tell you how often patients come to me who are in larger bodies, who have spectacular, diets, balanced, doing all the things that they need to do, very healthy lifestyle. And really, like, there's no more that they could do diet and lifestyle wise. They're doing it all. And, at that point, it's really about medication management, supplements, and really doing the best that we can to, stay consistent with all those changes. But we can't put all of the onus on the patient. We can't say this is your job to treat. That's ridiculous. We don't do that with any other condition. So it's ridiculous to do that with PCOS as well.
And really wanted to just highlight some of the intersections between the two. Felice or Erica, feel free to take this one.
Yes, well, one of the things that we're seeing in the literature is that individuals with PCOS are 4 to 5 times more likely to develop an eating disorder compared to those without PCOS. And that is huge. What we know is that there are over 28 million people in the United States with eating disorders. And again, a lot of times they are not getting the care, they're not even getting diagnosed, they may be getting overlooked. So I think this number probably is even higher because it's not like we're actually screening every single person with PCOS for eating disorders. So I think this is really, really significant. And that does translate to about 40% of people with PCOS having clinically significant disorder eating behaviors, as I showed previously. And what that can do is lead to increased rates of body dissatisfaction, anxiety, and depressive disorders. And then again, long-term complications if these eating disorders are not being addressed within the PCOS population. The other thing, and we kind of hinted towards this earlier, we talked about insulin resistance causing an increase in appetite and sugar and carbohydrate cravings, which can lead to binge eating. But what happens is when you're prescribed a diet and told to refrain from eating certain groups of foods, particularly carbohydrates, that can lead people to engage in restrictive behaviors, right? Skipping meals, counting calories, not getting enough for what their body actually needs nutritionally. And that can lead down a whole other cycle because what happens with restriction is that can also disrupt some of your hormones, particularly hormones like ghrelin, leptin, that can cause you to actually, your basal metabolic rate to lower. And that can cause other hormones to increase, like neuropeptide Y. I know this is a lot of science, but then that can actually increase your binging even more. So restriction actually leads to higher levels of binging. And I think that's really, really critical because that can reinforce the cycle that we actually already see with PCOS. So that's where really that intersection of eating disorder behavior and PCOS really can kind of amplify each other in a way. And that's why we really think that the medical interventions that focus solely on weight loss really do increase the risk of eating disorder behaviors and clinical diagnosis of eating disorders. And there is a lot of research, you all, about dieting. Dieting is one of the strongest predictors for developing an eating disorder. So we have to just be really careful. And if you are seeing a physician or a dietitian who's telling you to go on a diet, we have to be really careful because that again may perpetuate and actually amplify the PCOS symptoms.
One thing that I'll throw in here as well is I think that when medical care for PCOS focuses so much on the weight loss aspect, as it historically has, it really takes our attention away from the aspects of PCOS that really matter and really need treatment and influence things like weight. So getting insulin resistance under control, getting other hormones under control, and addressing those chemical lab values, to make sure that somebody's the healthiest that they can be. Those have, a tremendous effect. And if we think about dieting and what it predicts, it's one of the strongest predictors for long-term weight changes, greater changes, increases in weight as well. So even from a it works standpoint, it doesn't. It
Yeah.
doesn't even do what it's promising to do.
Yeah, what's so interesting
Mhm.
is like weight and
And
even
I
like
think it just leads to, oh, go ahead.
no, Erica, you go ahead. You're the expert.
Oh, go ahead, Joe.
I was just gonna say, well, I think what's so interesting is like weight and even like your labs are just an indicator.
Well, you
of-
are too because you have the experience.
I think there's a time delay there, Erica. I think we're all good now. What I was sharing is I think with even just like weight in labs, oftentimes it's like a snapshot of a moment in time, right? And it's not like your entire life. And one thing that I found really interesting is I could go 110% on like dieted and exercise for like the next month, and my labs and my weight might be perfect then, but like it's not sustainable. And I'm going to like it's going to throw everything out of whack when my body needs more nutrition and it's lacking that. And so I think what's so important is to see like look at this from a long-term standpoint. Like, and Felice, you and I have worked together so much on like creating small goals, like things that feel like they're attainable and they're doable, to really make sure that it's not like a massive change just to get perfect labs 1 month in, but like it's all going to go to nothing in a couple of months.
And one thing that we know about nutrition counseling and diet changes in general is typically the more slowly that you're working through those changes, the more sustainable they will be in the long term. The sort of all or nothing crash dieting, it doesn't work. So it really is about just changing one behavior at a time versus ascribing to an entire diet and flipping your world upside down.
Yeah, totally. Erica, wanted to get back to you.
No, I was just going to say, and I apologize. It looks like my internet is a little unstable today. Perfect timing for that, of course. But one of the things I was going to say is, yes, when that happens, I can only imagine the frustration, Joan and Felice, when you are being told to stick to something that is not sustainable, and how frustrating that can be, because when it's not sustainable, it feels like a sense of failure, right? And you feel like, okay, I have failed. And we start to internalize that failure. And that can also perpetuate the disordered eating behaviors, to engage in more restriction or more binging and purging behaviors, compensatory behaviors. And it can just lead down this cycle that's really, really hard to stop unless you're working with a team that can recognize it and you're able
Yeah.
to get the tools to really overcome it.
Yeah, definitely. So wanted to cover a little bit on some of the nutritional aspects and, undernutrition, malnutrition really being a huge part of that intersection of eating disorders and PCOS. So I'll pass it over. I think, Felice, you want to kick us off here?
Absolutely. So one of the first key distinctions I want to make here is that malnutrition or undernutrition does not necessarily equal weight loss. It just means that your body does not have all of the nutrients or all of the energy that it needs to be healthy, to carry out all of the necessary processes. Some of the first ways that we can see that are with the hormonal impacts. And that includes things like low estrogen, high adrenal hormones like DHEAS, impacts on fertility. So just general trouble conceiving. And it doesn't necessarily make a significant impact on testosterone, but it definitely makes a big impact on the ratio or relationship between testosterone and estrogen and other female sex hormones, particularly in PCOS. It also affects our HPA axis. So I'll let you take this away, Erica.
Yes. Oh, absolutely. And thank you for highlighting that. It's so important. That weight is not a predictor of health, which I think we hear way too much in social media and in medical clinics as well. But I think the HPA axis is really something important to highlight here too, because having a medical condition like PCOS is very stressful when you're dealing with, all the symptoms that you're experiencing, fatigue and hair loss and, challenges with your period, infertility. That leads to a lot of stress. And stress can also cause there to be hormonal changes as well through the HPA axis. And in addition to stress, we also know that trauma can impact that HPA axis. And that HPA axis, what it does is the hypothalamus in the brain is able to release hormones that then act on the pituitary, and the pituitary gland is then able to release hormones that act on the adrenal glands. And there's this beautiful relationship, but with stress and trauma, it can completely disrupt that axis. Another thing that can disrupt it is malnutrition and restriction and insomnia. So as you can see, again, all of these things, all of these factors can really disrupt the hormonal changes in our body. And that stress, all those stressors and a disruption of the HPA axis can lead to increased cortisol, which we know is a stress hormone. And that can cause decreased release of the LH, FSH, all of those hormones that are really important in regulating our cycles, and also can disrupt that LH, FSH ratio. And that can also lead to challenges with period, challenges with fertility. That can lead to decreased levels of estrogen and progesterone, and sometimes can even reverse levels of testosterone and DHEA given the level of malnutrition. And that can all reinforce the insulin resistance as well. So as you can see, when there is a combination of PCOS and malnutrition, that can actually disrupt the hormonal balances even more than what you would typically see with PCOS without adding restriction and stress to our bodies to the mix.
Just to add a little bit of, oh, sorry, I was just going to add a
Mhm.
little bit of nuance with the insulin resistance thing. Sometimes in the short term, or many times I should say, in the short term, undernutrition can cause or can look like some slight improvements in insulin resistance. And that's oftentimes why it is weight loss is recommended to so many patients is, during a short period of time, it seems like, oh, you're sensitive to insulin. It's great. But we know that having extraordinarily low, in addition to extraordinarily high, blood sugar levels are extraordinarily dysregulatory to insulin production, and that exacerbates the whole sort of progression of insulin resistance. So we don't want low blood sugar, just like we don't want high blood sugar. We want it to be consistent. We want it to be stable today or throughout the day so that our body can really respond appropriately and be as sensitive to insulin as possible. And that is ultimately, in the long term, what improves insulin resistance the most is the blood sugar stability.
That's such an
And
important
that's such a great
clarification.
point. Yeah, such a great point, because with hypoglycemia or low blood sugar, we know that that is a sign of malnutrition, right? And that can have other physical impacts on the body that can, again, exacerbate some of those baseline PCOS physical symptoms.
Absolutely.
Love that. And I think some great segue right there into some of the medical symptoms of eating disorders. Erica, you want to take us away?
Absolutely. Well, since we're already on the topic of hypoglycemia and low blood sugar, right, that can absolutely cause fatigue and low energy and difficulty concentration. And those are all signs that we see with eating disorders as well, with malnutrition, fatigue, low energy. As we know, Joan talked about that earlier. Fatigue is one of the hallmark symptoms of PCOS. So when we are malnourished, that can actually further worsen the fatigue and the low energy because it just makes matters worse. We could see hair loss or alopecia, sleep disturbances. So again, we know that sleep insomnia can be a feature of PCOS, but malnourishment can actually make insomnia worse. Headaches, dizziness. The other thing that we'll see, there are cardiac problems that can occur with eating disorders and malnourishment, um, all the way from chest pain to heart palpitations to cardiac arrhythmias that can be due not only to malnourishment, but also other types of compensatory behaviors like purging behaviors and laxative or diuretic abuse that can actually lead to sudden cardiac death. Cold intolerance, hot flashes, those are things that we could see with PCOS that malnourishment can actually exacerbate, as well as abdominal pain, constipation, nausea, vomiting, even blood that can come up with as they're vomiting. I mean, there are lots of other GI symptoms that can occur with malnourishment. The other thing that you've heard us highlight, light, absent, or irregular menstrual cycles, and infertility concerns. All of those things can be features of eating disorders as well. And then, of course, we'll see muscle wasting and osteoporosis for some individuals with malnourishment. So this slide is really just a highlight the overlap between some of the PCOS symptoms and eating disorder symptoms and how those physical symptoms can actually be made worse with eating disorder behaviors.
Thanks. Oh, there we go. You covered it.
Oh, well, there we go.
Anything we might have missed that you want to cover on the slide here?
I just want to point out one of the ways that we can see undernutrition sort of layer in with PCOS. It's specifically in regards to the irregular absent menstrual cycles. Sometimes when patients are initially trying to make some of those nutrition changes and they're erring on the side of undernutrition versus adequacy, it can be difficult to figure out really, is your missing cycle from undernutrition? Is it from the PCOS? There can be so many drivers.
Mhm.
And in the most extreme sense, this can be its own condition, hypothalamic amenorrhea, which is basically your body doesn't have everything that it needs to have a period. And the adapted lower metabolic rate that is associated with undernutrition, meaning as you're under eating and your body adjusts, and what was a calorie deficit yesterday is no longer a calorie deficit today, that process can worsen insulin resistance because your body is really trying to be as efficient as possible to hold on to as much energy, to slow things down and just make sure that you're safe. That lower metabolism feeds into what we call lower glucose utilization. So if your body has to adapt to having a lower metabolism, it's not going to utilize all of the blood sugar that's available properly throughout the day. And that can feed into this cycle of insulin resistance. We know that the greatest predictor of metabolic syndrome, which is often kind of lumped in with just the overall naughty word of obesity, is restriction. We know that restriction is one of the greatest predictors of this. And, there are so many other ways to manage PCOS. There's so many more impactful ways than just restricting yourself. Why take the risk with all of the other risk factors for disordered eating? Let's try something else first.
Love that. I know we provided a lot of background here, and I think a lot of folks are probably wondering, okay, so I really want to avoid disordered eating, and I also need to manage the PCOS. So like, what do I do? So would love to kind of give some tactical advice to folks on, what are some ways that I can actually really address my PCOS without developing an eating disorder?
So a lot of it goes back to insulin resistance, as I've probably said 50 times already today. And it also comes back to reducing inflammation. The root cause of really any sort of hormonal disruption is some type of inflammation, some type of dysregulation in the body, whether it's from insulin resistance or other things. So rather than focusing on weight loss, BMI, those sorts of things, let's look at what symptoms somebody is actually experiencing and address those. Look at that picture and figure out what is the root cause and track those as our main outcomes over time. we can do that. We can make changes through an adequacy mindset. Sometimes I call it our enoughs. We have to get enough movement, enough nutrition, enough sleep, enough mental health care, stress management, all of those sorts of things. Those are what's going to be able to address whatever source of inflammation we're experiencing. Addressing underlying stressors or traumas, exploring the relationship we have with food, body, physical activity. Balanced meals and snacks and eating regularly throughout the day are a wonderful way to manage blood sugars, keeping those stable, making sure that you're working with an interdisciplinary team, and refrain from associating eating exercise with any sort of judgment, positive or negative. Just because you weren't able to eat the way you wanted to or get your walk in or whatever it was, doesn't mean that you're a bad person. It means you probably had a lot of things on your plate and we do the best we can to prioritize. And it also doesn't mean that you're a perfect, amazing, stellar human being just because you did do those things either. So yeah.
Yeah, I think you make such a great point of like removing the morality and judgment associated with, food and with exercise. And I think that has been such a process for even me to just explore in this journey of, being in recovery from an eating disorder and now managing PCOS is how do I start to think of movement and exercise in a different way than I had before? Because I think it was so difficult to move from like this obsessive need to go exercise and then go to like, I to protect myself, I need to just not go to the gym at all, to like, okay, well, how do I start to introduce some movement, like enough movement into my life? And just like, and it doesn't have to be like movement and exercise to punish myself. It could be associated with so many things like going for a walk with my family. I remember I had a therapist who was just like, just try like 5 jumping jacks, like it doesn't have to be a lot. Like, let's just get some movement in. And I really appreciated just the the shift away from that all or nothing mindset and this idea that like, oh, I have to punish my body because it's bad, because it has PCOS, and more just like, we're going to work together. We're going to figure something out, body, and we're going to manage this PCOS together.
And Joan, as you mentioned that, I think that's just such a great example. I've even pulled away from exercise because I think exercise can be such a loaded word, right? When we hear exercise, we feel like, oh, I have to do it, or there's like pressure to do it, versus movement. Movement can actually be fun, like dancing or hula hooping or, skating. I mean, there's so many other ways to move our bodies in ways that honor our bodies and can be really fun rather than, like you said, punishing it and feeling like, okay, I have to do this to make up for what I ate. That's one thing that's like, I think I hear so much is like making up or having to earn food by exercising. It's like, no, that's actually not how this works. We want to fuel our body because we want to honor our bodies, and we could celebrate that by moving and doing things that are really fun.
Yeah, love that. And we talked a little bit about some of the inequities and just the lack of getting diagnoses if you're a person in a larger body or a person of color or LGBTQ. And I think there's so much we need to do to really advocate for ourselves in that physician's office and any doctor's office. And I remember this experience being really difficult for me because I kind of grew up in a family where we're like, the doctor is God, listen to your doctor. And like, it was kind of like, whatever the doctor said, like, you got to go 100% at it. And it really wasn't until I, started experiencing just like my own eating disorder and seeing some of the challenges in the system that I recognize, like, oh no, like doctors are humans too. And actually shifting away from that perspective of like, oh, I need to do what the doctor says. But rather thinking about them like as part of my team, and like that is a team that I am also on, and that, if I disagree with something or I have questions about something, I have every right to ask for that question or ask for clarification. And I just remember, I think in particular what helped me was I've developed a lot of community and friends who also have had eating disorders and hormonal conditions, and hearing some of their experiences really encouraged me to actually better advocate for myself. Because I would think, okay, when I go to the doctor's office, I am afraid to tell them that I want a blind wait or I don't want to be weighed at all. Because I'm afraid that like someone's going to roll their eyes at me or they're going to get in an argument with me or like, make me feel little or less than. But then I think like, if I don't do this and like, I have a friend who's struggling and who's coming in and, they feel less than, like, I wouldn't want them to be in that position. So I like feel like I have to do this and I need to step in and like actually try to create a better system for others as well. That's actually helped me stand up more for myself, I would say. And I think at Arise, we have care advocates who actually really take that role of like, let me step in and like, let me attend your appointments with you if you want, and really help kind of advocate on your behalf and really make sure that you understand what your treatment is like, that you understand how things are working and can, push back when things don't feel like they're working for you. But Felice and Erica, I would love to hear a little bit about, any tips that you have on how folks can really advocate for themselves in the doctor's office.
Wow. Well, as a doctor, I think it's really important. All the things that you shared are really important because you're right. It really requires a collaborative process. And I think that's so important. And if your doctor is prescribing things or telling you what to do and you're not feeling heard or seen, or you have questions, or you're after hearing this webinar, you go back and you're like, okay, well, help me understand why we're focusing so much on weight. Can we focus on my symptoms? What are the markers that you're looking for to show improvement in my PCOS, rather than focusing so much on a BMI or a number or a scale? So I think that's really important. And one way to do that is to search for teams that are really weight inclusive, who have a background in eating disorders, or at least an understanding and a sensitivity to it. There are a wide range of providers who identify as HAES, Health at Every Size providers, that really don't discriminate based off of weight and don't dictate all of their medical decisions based off of that BMI or a number on the scale, but they're more inclusive. So I think that's really important, is, finding that team that's sensitive, but also a team that's going to listen and to collaborate with you. And then lastly, focus on those targets, those specific symptoms that you want to address with the PCOS.
Those are wonderful tips. One of the things that I'll suggest to patients before they have what might be a scary appointment is to just write some things down beforehand. Bring a journal, bring a piece of paper, and write down literally verbatim what you want to say when it comes to time for you to get weighed. You can ask for a blind weight. You can ask to be weighed after your appointment. You can ask for a number of different accommodations there, maybe not even to be weighed at all, if it's not medically necessary. I would also recommend going into your doctor with some of the things that you feel you've been doing successfully that you think have improved your health, some of the concerns that you have, or the areas that you're hoping to be able to work on, getting their perspective on those, making that a conversation. And then there should never be pressure for you to decide what you need to do with your care in the moment while you're sitting across from them. You always have the right to go home, to look at whatever treatment they're recommending, to get a second opinion, to phone a friend, whatever it is, before you make that decision. It's very rare that there's ever an emergent situation where, like, you have to make a choice right there. You can wait as long as you need to feel comfortable and confident with that decision. It's a red flag if you're being pressured into something that you are not ready for.
Yeah, what gives me a ton of hope is actually the care teams at Allara and at Arise, where there is such focus on choice and autonomy for the individual. And I think that set a new standard for me when I go to different doctors. I'm like, well, if my care team at Allara, or like if the Arise care team can do this, then like you can too. And it just shows that, like, you can have providers who care about you. I remember, I think, Felice, when we work together, like, you always will ask, like, does this feel like it actually works for you? And just even being like encouraged to think, like, does this actually seem realistic, or am I just setting myself up for failure, is so critical. And I really love that our teams have such a focus there. And I think it starts to really, I think, demand that other providers start doing the same as well. So wanted to just go through some Q&A because I know folks had some awesome questions, and in the last 10 minutes, we went through some of the questions and summarized, but maybe we can go down the list. And if folks have any additional questions, please feel free to throw them in the chat. Would love to just make this interactive, but Ozempic, let's not start with the hot button item or anything.
Lots of press about Ozempic, and as you know, so many people have been requesting Ozempic that people with diabetes can't even get it. And I think the reason is because once it was marketed as a medication that can aid and assist with weight loss, a lot of people have been requesting it, and I think it could be quite dangerous because again, it emphasizes a number on a scale, which again, weight isn't a marker of health. There's so many other markers for health. And then the other thing I think that comes up for me is what happens when you stop Ozempic. So to me, it's almost very similar to dieting, that a lot of people, when they start it, they feel like they have to continue it. As soon as they stop it, they will see weight increase, and that can again fuel restrictive behaviors. It can fuel a lot of negative self-worth and self-esteem. So I think that can perpetuate again some of the same behaviors that we see with dieting, essentially. Curious your thoughts, Elise.
Yeah. Ozempic is one of those things that I definitely had to examine very, very, very carefully before I was able to form an opinion, because it's this extraordinarily powerful medication that, as you said, has been marketed as this magical weight loss drug when it was truly intended to just help people manage their blood sugars. And what I'm seeing, with my patients, my experience so far with this medication is that it goes back to it being an extraordinarily powerful drug. If there's nothing else that is helping somebody's blood sugar, if we've literally tried everything else, sometimes that, ends up being the last resort for patients' health and safety. But it comes with so many side effects, and it is something that can be very, very triggering for a lot of disordered eating behaviors. It truly makes people feel like no interest in food, lots of nausea, and lots of almost, if you were to eat, like it wouldn't feel good for your body. So it's very difficult if you additionally on top of that have this history of disordered eating and already have a strained relationship with food. It's very difficult to get yourself to eat enough to not become undernourished. And that comes with issues with lots of muscle wasting, lots of electrolyte imbalances. And I have seen patients that have to be sent to the hospital because they aren't able to keep up with what they need to because of the physiological pressures of this drug. So definitely more of a last resort, can be helpful for some, but there's so many options out there.
Yeah, so appreciate the nuanced perspective there. And orthorexia, I know we got that one a lot, but I feel like there's such a blurred line there with orthorexia and like so much of the just diet culture that we live in and like healthy, clean eating. So yeah, can you walk us through a little bit about what orthorexia is and and how do you identify that?
Yeah, so orthorexia, again, it's not a official eating disorder diagnosis, but I do think that a lot of the behaviors can be consistent with disordered eating behaviors. So a lot of clean, quote unquote, clean eating, cutting out carbs, cutting out fats, excessive exercise to the point where there's guilt or shame if you miss a day of exercise, or again, you're using exercise as a way to make up for nutrition that your body needs, the nourishment that your body needs. So it's an overly compulsive approach to eating and dieting and exercising that again can be a very fine line to developing an eating disorder. And I think part of what we see, I can see the overlap in terms of some of the recommendations, and I do just want to make sure I acknowledge your question in the chat. A lot of folks will sometimes prescribe cutting out carbohydrates altogether. And we see that with a lot of diets, right? Low carb diets. I think that could be very dangerous because, again, carbohydrates are actually necessary. Like our body actually likes carbohydrates. We need them to function and survive. And I think carbohydrates get such a bad rep, and especially with PCOS, right? I think if we can teach a healthy way of incorporating carbohydrates and actually having consistent meals throughout the day, to make sure, again, Felice mentioned earlier, right? We don't want glucose levels to be sky high, but we also don't want the glucose level to be super low. How do we find that medium? It's important to incorporate carbohydrates in our diet, to make sure that we get that consistent level of glucose. So that those can be some of the dangers with orthorexia as well, when we are cutting out certain food groups and really just missing out on key nutrients that our body needs. Like our body needs fat. You know, our brain cells, our neurons actually communicate better when there's fat in the brain, because it helps those neurons communicate even faster, right? So fat is healthy for us. Carbohydrates are good for us, but we have to pull back from this all or nothing approach to food groups and the judgment that comes alongside of labeling carbohydrates or fats as bad.
Yeah, I've loved I think Felice actually taught me this, just adding things instead of just taking things away. And you know,
Mm,
I've even noticed that, like, you know, when I add vegetables or add protein with that carbohydrate, like the peak doesn't spike as much as it does. You know, there's
yes.
other things to get, like, really go with it. And that has been, I think, really a really helpful mindset shift for me of like, oh, I don't have to just like not allow myself something. If I just add something with it, it actually really kind of balances out. If I have more frequent meals throughout the day and like don't forget to eat all day and then like eat a whole, like, you know, a whole thing at the end of the day, then like that actually really helps. And that it doesn't have to be like fresh vegetables and like the cleanest, you know, Instagram you know, worthy bowl. Like it could be like frozen vegetables and like I can microwave it and like call it a day. Like it's whatever is accessible and doable. And I really loved that approach, to just like, let's figure out what's realistic.
Absolutely. And just bringing up a point that I made earlier, that low blood sugar is just as inflammatory and dysregulatory as high blood sugar is. Our body wouldn't be converting the proteins and the fats to glucose if carbs were bad for us. You know, we need carbohydrates absolutely, and actually they need to make up the majority of the energy that we intake throughout the day. Um, and all the plant-based food groups are, which we know are the more anti-inflammatory food groups, those are all carbohydrate food groups: fruits, vegetables, grains, beans. These are all things that we know the healthiest populations in the world eat regularly. And then I wanted to tie in the one question that I saw about concerns over gluten. Uh,
Mm, mhm.
Inflammation is a driver of PCOS. So if you have a gluten sensitivity, if you have celiac disease, if you have any sort of condition that makes you sensitive to gluten, absolutely cut it out. But when people unnecessarily cut out gluten, gluten-free diets are low in fiber, B vitamins, magnesium, selenium, and some other really key nutrients that we get from our gluten-containing foods. Many of our grains, our whole grains, contain gluten outside of wheat. So that could be farro, that could be barley, that could be rye, spelt. Um, there's so many, and whole grains are one of the greater consumption of whole grains is a greater predictor for insulin sensitivity, for blood sugar stability. Eating them consistently, ideally in their more fibrous form when you can, throughout the day is what we see being super, super important to study blood sugars.
Yeah, really, really helpful. I know we are running up on time and I wanted to answer one of the questions in the chat. Felice, you might be able to take this, but someone said that they're prescribed birth control for PCOS. Does birth control make PCOS worse?
I think, I wish there was an OBGYN here to answer that question. But I'll just try and do my best to parrot our great minds over to Laura. And I would say no. Birth control can be a wonderful tool for managing PCOS. It just helps us make sure that people are their endometrial lining is not getting too thick. Maybe they're getting their withdrawal bleeds regularly. So it can be a wonderful tool if you aren't able to get your cycles regular without them.
Awesome. Well, I know we still have a lot of questions that we have to answer, but we are running up on time here. And maybe we need a part two and address some of these. I think there's so many questions on just like ways to make it tactical, right? Like ways to manage the cravings and, the role of binging and how do we manage the insulin resistance. So I think we might need a part two to answer some of these questions. So thank you
Yes.
all for joining us. And thank you, Erica and Felice, for just such a thoughtful and nuanced conversation tonight. And as for anyone who's interested and has a history with disordered eating or eating disorders, you can visit our website at wearise.com. We have a comprehensive team of therapists, dietitians, psychiatrists, PCPs, as well as care advocates and group support. So would love, we're only seeing folks in Texas, but we're going to get to your state soon, I promise. But feel free to visit us and reach out if you have any questions. And Allara is awesome. I am a member with Allara, so cannot recommend them enough. But please check out the Allara website. It's a really awesome team that's really just so nuanced. And I think I'm just so grateful for the existence of our care teams because we're really changing the landscape of healthcare and really centering the patient's needs and experiences. So thank you both for all the work that you do to care for our members.
Thank you. Thank you all so much for joining.
Thanks,
Thank
everybody.
you all.